The next session is on newer molecules on the horizon for treatment in osteoporosis. I would like to invite our next three chairperson for this session. Lieutenant General Dr. Ved Chaturvedi sir, who too needs no introduction at all. Dr. Ved, with his vast clinical experience in this complicated field, is certainly an inspiration to us all. He is currently working as a senior consultant at Sir Gangaram Hospital. Welcome, sir. Next, I would like to invite on stage Dr. Varun Dheer. He is currently working at PGI Chandigarh as assistant professor in the Department of Internal Medicine. Welcome, sir. Now, I would like to invite our third chairperson, Dr. Danbir Bhadu. He is working as assistant professor at AIIMS, New Delhi, in the Department of Rheumatology. Welcome, sir.
Next on agenda is my own teacher, Dr. Ramnath Mishra. Before I introduce him, I think I request him to come on the dais. I can tell you, the first DEXA machine of this country came to SGPGI. And it came to rheumatology department. I hope Sushil is here. I was asking Dr. Mishra, it came to two places. It came to Army Hospital and it came to SGPGI. Almost the first came to SGPGI. And we didn't have place to keep. That is how it went to endocrine department. You'll be surprised the interest of how the rheumatologists didn't take much interest in osteoporosis. Otherwise, this machine DEXA scan, and to the youngsters I must tell you, they may not have seen. The India Today published DEXA machine on the main page with the endocrinologist, I think Sushil Mittal, Dr. Mittal. So that is, when I joined my DM program in SGPGI, this man who is standing here, he was heading the department. And I can tell you, when you go from army, you ask who's the boss. So somebody says he's the boss. So I went inside. A lot of people, especially, will always say boss should behave like a boss. He never behaved like a boss. He was a friend, philosopher, guide, and I can tell you what not. एक शेर है उर्दू का, वो कभी मैंने भेजा भी होगा किसी को, कि लगा ना सका इसके कद का अंदाजा कोई, लगा ना सका इसके कद का अंदाजा कोई, वो आसमां था मगर सिर झुका के चलता था. डॉक्टर मिश्रा.
Thank you, Ved, for the kind introduction, and thank you all the senior members of the DRA. I am indeed privileged to be invited by DRA, and I think this is the second time that I've been invited. Well, it just adds pressure on when you are speaking at a DRA meeting. I usually think that people are very knowledgeable here. You can't just do a scrappy job. I have to submit that I have not done any work on new molecules of osteoporosis. So maybe Rajiva is very kind to invite me, but don't ask me questions which are very basic. I have not done any work. What I will try to wish to communicate to you is the complexity of osteoporosis and how, unlike other diseases in rheumatic disease, targeted therapy, as we say, is not such an easy thing in osteoporosis. Osteoporosis is a very complex, complicated disease. In order to understand the complexity, may I use this cartoon from Nature Review Rheumatology. It's a kind of dissect the bone to tell you that the bone is composed of small tiny units, you may call it osteon, like the nephron for the kidney. And each of these, can I use it? Oh. It's not working? Okay, can I use the cursor? No, I can use the cursor.
LED it's not working. That's because of LED. It
Oh,
can't.
this is an LED. Yeah. Oh, you ought to have a blue or a green thing that works. Red doesn't work.
So you can use the laptop. There's a marker there.
Cursor. I'm not good at Dell computers. Anyway, these tiny circles that you see are called the osteon, or the tiny units. Each of these bone have a unit called BMU, bone multicellular unit. It has three components in it: the osteoblast, the osteoclast, and the cell that is produced the matrix, the osteocyte. All that you have heard in the morning, that 70% of the BMD results are fallacious, means those who have a fracture, 70% of them do not have a T-score of less than 2.5. Why is that? What the BMD measure is the bone mineralization. It doesn't measure the microstructural abnormalities at all. So we rest on whether the BMD is improving, how frequently to BMD. It's all a fallacious notion. You can do it every yearly, but you are measuring the secondary deposits of mineralization that has occurred following therapy. That's it. It doesn't improve the functional quality of the bone. And the second thing is, to give a picture of that, at the periosteal region, there is maximum bone laying down, and that is evident in younger age when the metaphysis joins with the diaphysis. At the center, where the bone is hollow, there is maximum osteoclastic activity. Now what happens, your drug, that is alendronate, it somehow localizes in the intercortical region, in between the cortex and the trabecular bone. The trabecular bone is really spongy. There, your alendronate doesn't reach. Your PTH and denosumab, that is uniformly distributed. So they have a little theoretical advantage on that front. And what happens around menopause? We are talking about postmenopausal osteoporosis. What happens is, around perimenopausal period, lot of crypts appear in the bone, holes appear in the bone. In this osteoid unit or the BME unit, the functionality starts with the osteoclast. The osteoclast then drives the osteoblast. So the osteoclastic activity, there are crypts appearing at the perimenopausal time, and that causes a sudden rapid decline of the BMD. And this gradually is filled up by the osteoblast. The yellow things are the mineralization things. As the osteoblast lay down to fill up this veil, you can see that yellow thing, that is recovery, that is the holes are recovering. This has significance. In a younger age, it's called a reversible deficit. Even if you have a deficit, the osteoblasts are good enough to fill the entire crypt. But at a time around menopause or with age, say after 70 years in a man, when the crypts occur, they are never filled up completely by the osteoblast, and mineralization is always inadequate. Moral story of the moral is, No drug can ever take care of the age-related osteoporosis or the postmenopausal osteoporosis. No matter how many new molecules would come, they wouldn't. There is some problem there. But still, do we have a remedy? We have been talking about drugs. We know that drugs like bisphosphonate, which predominantly act on the osteoclast, is basically, it acts on the enzyme of the cytoplasm of the osteoclast to kill it. So osteoclast is lies through caspase activation. We have drugs like estrogens, which also have effect. They are called as a weak resorptive, anti-resorptive therapy. And then we have drugs on the right side, which are teriparatide. Teriparatide works both on the osteoclast as well as on the osteoblast. What it does is take away the old bone and fill them up because of osteoblastic activity, which the bisphosphonates or the estrogen mimickers, they cannot do. So in a way, you get a little bit better remodeled bone with parathormone. As is all evident to you, the therapeutic options lie on anti-resorptive agents. We have bisphosphonates, denosumab, and the estrogens, and also anabolic agents like PTH analog and sodium fluoride. Strontium ranelate is not available here. It is a dual agent. And we have to deal with the nutrition, the lifestyle, the calcium, and the vitamin D supplement, as has been emphasized. I mean, they are the must. If we compare the two main drugs, that is the anabolic agent and the anti-resorptive agent, the anabolic agent, as is the name suggests, it forms new bone. The anti-resorptive agent, it suppresses bone resorption. So it is predominantly works on the osteoblast as opposed to the osteoclast. It accelerates turnover. It accelerates the BMU, the anabolic. The anti-resorptive agent, it downregulates the bone. And that is not good always, because if you downregulate the bone, some quality of the bone, the flexibility of the bone is reduced. The rigidity of the bone increases. It forms new bone, and that is called as increased bone volume. There is mineralization of existing bone, and we have the drugs that is shown below. This is where bisphosphonates act. The second and the third generation of bisphosphonates have nitrogen residue on their chain, and they worked to the enzyme that converts mevalonate to farnesyl PP, and that causes problem of isoprenylation of the osteoclast. It eventually, as I told earlier, that the osteoclasts are killed. The osteoclasts lose its activity of, whereas the denosumab is an antibody to rank ligand, and the rank ligand are shown in green circles, and rank is there on the osteoclast. It is the main mediator, immune mediator of osteoclast activation. Therefore, by giving rank ligand, antibody to rank ligand, the rank ligand rank axis is blocked, and the osteoclast undergoes apoptosis. So both apoptosis occur with bisphosphonates as also with denosumab. However, if you focus, I mean, this is the same diagram showing how the anti-resorptive is effective at a molecular level. Both, if you compare the if you see the bottom panel here, the bisphosphonate will improve your BMD to a certain stage, and then it is static. It can no longer, after 3 years, BMD is not expected to rise with bisphosphonate. Whereas with denosumab, you not only get increased BMD rise from the start, it continues up to 10 years, I mean, as long as it is given. With weaker anti-resorptive effect, there is a gain in BMD, again they will fall. I mean, drugs like estrogen and SERM, they will fall again. So bisphosphonate has, the BMD report has to be understood in this context. You don't expect BMD to rise with bisphosphonates after 3 years of therapy. And as we are told that after 5 years of therapy, there is no point continuing in BMD. These drugs, anti-resorptive, as you have sensed, are far from cure. Their concentration is low. Bisphosphonate concentration, as I showed in the bone map, very low in the deep cortical areas, and the osteoclastic resorption continues to happen, and the mineralization is slow. Whereas with denosumab, it's widely distributed throughout the cortical and trabecular bone. The mineral content of the total bone matrix volume increases, but total bone volume, matrix volume might not decrease. There is not a more scope of remodeling, and remodeling is essential to gain back the quality of bone that we have lost. So there is a scope of new drug, bisphosphonate and rank ligand inhibitors like denosumab reduces the vertebral fracture by about 70%, of hip fracture by 40 to 50%, and non-vertebral fracture only 20 to 30 fracture. It inhibits bone resorption. The table on the right will tell you that alendronate can increase BMD gain to 5 to 7% and reduces fracture risk by 30 to 40%. Ibradonate 4 to 6, fracture risk by 30 to 43%. Denosumab, in comparison, increases BMD by 3 to 6, reduces fracture risk of vertebral fractures by 55 to 70%. And therefore, as you can see, come to the bottom of the table, teriparatide, that increases BMD by 10 to 15% and reduces vertebral fracture by 50 to 65%, not 100%. The BMD increase is not. And I told you theoretically how the BMD cannot be increased, but still PTH, as has been discussed, it has an advantage. You see the bone that has been aged has got crypts, old bones. Someone has to actually, if you want to make a repair of that bone, has to take away that old bones, refill with new bones, and then the matrix has to come in. So in the multi-cellular unit, the BMU, parathermon has the potential to remove the old bones by improving the osteoclastic effect and lay down the osteoblast lays down the matrix, which can be primarily mineralized or secondary mineralization. Primary mineralization occurs within months, but secondary mineralization occurs after months to years. So BMD therefore increases. Best is to do after a year or 1.5 years. Don't do it earlier. That is all how the molecules act. Now, where are we? What is the new? I'm coming to new molecule number 1, and that is a synthetic peptide which is analogous to parathermon. That is called as abolaparatide. our teriparatide is 34 amino acid. It is synthetic, but it contains the same structure as the original parathormone. This has got 36 amino acid. Only the first 2 amino acids are similar to the parathormone peptide. Yet, it works better than the parathormone, both in animal studies. In animal, you know how they do osteoporosis. Adult rat, they do overectomized. And then you get a model of postmenopausal osteoporosis. If you see the increase in bone mineral content, SGPGI stands for abaloparatide. That is what the scientists had framed the name. And as compared to PTH, over a 6-month period, it had more bone volume than paratide. And human studies, it is slightly better as compared to PTH, but it is given daily, subcutaneous given daily, as compared to you give 20 microgram here, there you have to give 50 microgram, but it has to be given daily, subcut. And both at the it reduces non-vertebral fracture, clinical fracture, and major osteoporotic fracture. It performed better than or PTH. And because it was a new drug, the patients selected all had a previous fracture. It has not been tried in patients whom we would put in the drug. Either they have failed on bisphosphonate, but they never had a fracture. They have a low minus 2.5. But this had a rigorous test that patients who have had fracture, they were put on this. We need more patients to be included in this before. Actually, at a bone marker level, PTH performed better than the abaloparatide, both the molecule, the urinary peptide and the serum peptide. PTH, the adverse effects are dizziness, nausea, headache, and leg cramp. It was the same with abaloparatide. We have got another molecule, anticathepsin K. Anticathepsin K is a proteolytic enzyme which the osteoclast use to dissolve the matrix. It's a proteolytic, and it's a very powerful bone enzyme. This molecule, odanacetab, is a cathepsin K inhibitor, and we have a trial called the LOFT trial, and the primary outcome were robust. They included vertebral and hip and non-clinical fractures, not just improvement of the BMD. I mean, after all, why do we use a drug? We use a drug to improve the fracture risk. And the secondary endpoints were clinical vertebral fracture, BMD, and the participants were postmenopausal women who had never been exposed, at least in the past 6 months, to any bisphosphonate therapy. However, this study was terminated because of increased cardiovascular event. So new molecule number 2 gone. We have a molecule here which had been kind of mentioned by Shankar. Is a molecule called sclerostin, which inhibit the osteoblastic activity, which is mediated through the WNT and the canonical beta catectin pathway. It forms bone, and sclerostin inhibits that. Those human beings who are genetically mutated for this enzyme, they have, so they can't inhibit the bone formation. They have massive bone mass. They have huge mandible. And you can also, if you knock out this sclerostin molecule in mice, they have very robust bone. I mean, that is why we get the evidence that this can be tried. we have an antibody, monoclonal antibody directed against sclerostatin. This is the frame fracture study, and this came up with very exciting results. They received 200 milligram subcut or placebo once a month for 12 months, and this was followed up by denosumab for another 1 year. So denosumab is an anti-resorptive therapy. This is an anti-resorptive therapy and also have osteoblastic effect. The result of this study is shown here. Remember, they were given only for a year, and the second year denosumab was given. The green panel, the green area that showed the improvement at the lumbar spine as compared to the placebo on the left, and the improvement was obvious as early as the 6th month onward. And if you, I'm not able to point in a cursor, on the right hand side, if you see, this has been compared with another blue line which is going way through the corner. That is from a denosumab freedom trial, where denosumab was given for 10 years. And what was the investigators pointed out that the improvement in the mean BMD was same as was achieved by denosumab after 5 years. So you can see the accelerated improvement of BMD with romosozumab. Those are the comparator. You get that at 1 year is compared with 5 years, both at the lumbar spine and the total hip. Then we have a trial where romosozumab is compared with our seat anchor drug, that is alendronate. Alendronate is like methotrexate for rheumatoid arthritis. All drug they have to compare with alendronate, and alendronate results are not bad if you see. I don't know, in osteoporosis, large number of patients are tried as compared to these 100, 200 patients of rheumatoid arthritis. These are trial of 2,000 patients in each arm, and the circle, black circle, denotes how often X-rays were done, how often DEXA scan was done. That was done 6 months, 1 year, 1.5 years, and 2 years. This, the double-blind period is just for 1 year. They were compared 70 milligram orally every week. Is any of the resident or junior fellow who is sitting in the back, can they suggest that how you compare a weekly oral drug with a parenteral drug which is subcutaneously given every month? Anyone? I mean, it's a random. 2 groups are there. How do you compare an oral drug, and the patient has to be blind about it? Can anyone suggest? You are giving an oral drug once a week, and you are giving an injection to the other. I mean, I didn't ask this question just to wake you up, but I thought my lecture was getting boring. Yes. So what do you do that? So yeah, you sit down. I was not expecting answer from you. I know you would tell that. Actually, when you answer that, I feel much of the excitement in me is lost. Yes, he is right. You have to give a placebo injection to the placebo group and an oral placebo to the group that is getting placebo. So you are brilliant. In fact, if you see this thing, I don't know whether you can see the incidence of new vertebral fracture. The first one, the empty histogram, is that of alendronate, and that of the shredded one is that of romosozumab. And you can see that both at 12 months. At 24 months, everybody was receiving oral alendronate. The results of previous exposure to romosozumab was good. I mean, it was better. It was statistically significant. And then this change in the bone mineral density, or the BMD, is evident. You can see a wide gap between the two lines. This drug has also been compared with teriparatide. 436 patients, and they have had a 12 months trial. The mean percentage change from baseline in total hip area, BMD was 2.6% in the romosozumab group, and in the teriparatide minus 0.6%. So it scored better. It was this result and the earlier result. That study is called the ARCH study, where romosozumab is compared to alendronate, led the FDA to approve this drug as early as April 2019. So this is a new drug for postmenopausal osteoporosis. However, there are a group, Kosman et al., found that the level of this bone marker suggests that there is reduced bone remodeling. And I told you at the beginning, PTH advantage is that new bone remodeling occurs, and that is advantage to give not only leverage of the bone, but the flexibility of the bone. So we need to see more trials. And there is always a chance of osteonecrosis can occur with this new drug. Osteonecrosis doesn't occur with PTH, so but there is a possibility that it can. We have two newer drugs in the pipeline. SIT1 stands for sirtuin. Sirtuin is a protein which is synonymous with aging. Sirtuin activity lessens as we age, so it is less in me than in Varun. And to try to this, there are, it's a NAD dependent enzyme. There are agonists of sirtuin that is trying, and that may help also male baldness, they say. So it's very refreshing for our age group people who are about to retire like me. And there is another sodium, hydrogen potassium ATPase pump inhibitor, but there are only proof of studies in animal. And I'm not sure whether this crowd gets very excited, things happening in animal. They would like things happening in diseased patients. This is not new, but this is a meta-analysis study to show that the current trend of osteoporotic treatment is that to use anabolic drug first, follow up it with anti-resorptive agent, or you use anti-resorptive agent because the first line drug is bisphosphonate. After some time you don't see your BMD improving, or there's a new fracture coming in, to change over to parathormone. Or there is another school of thought, why not give to the affordable ones, at least in Delhi, both. Give alendronate, give PTH, what is wrong? Now the overall result is that if you change from anabolic to anti-resorptive, the mean improvement in the bone density is 3.6 in the lumbar spine. But if you use an anti-resorptive and then go to anabolic, then the improvement at the end of 5 years is 5.6. So I would still tell to my students to use anti-resorptive therapy first, that is the first line drug, and if there are events or if it doesn't. But if you give a So you give overall the response is 3.59. This is the standard recommendation of the American College of Endocrinologists, which has catered into those who have had fractures before, that is on the right side, they are poor risk factors, and those who did not have fracture. They still use alendronate, denosumab, risindronate, and zoledronic acid, but they are very clever. They say that these drugs are written according to alphabetic names. They are not according to evidence that this drug is better than the other. And the alternate therapy is ibradronate and raloxifene, and you have to assess your patients after a year, no, not earlier, and with BMD or fracture risk, and change as is suggested. So we still, the FDA approved drugs are alendronate, ibradronate, risindronate, zoledronate, calcitonin. Calcitonin is a nasal spray, by the way. Teriparatide, denosumab, and romosumab. Thank you. I would like to stop here.
Thanks, sir. Thank you.
Yes, sir. Dr. Bakudi.
So of course, you are my teacher also. I'll ask a very simple and practical question, sir. What are the recommendations for repeating teriparatide after, say, 18 months or 24?
There is no recommendation. Max 2 years.
That's what to do after that, followed by anti-resorptive. That's all. Thank you.
Is there
Well, that you asked a question, that means my lecture was inadequate. Yes, Vinay.
Is there any role for raloxifene or calcitonin nasal spray in our practice? After the arrival of the newer drugs, you are still using it or they are obsolete?
Well, the last word is correct, I think. They are obsolete. Not many rheumatologists or endocrinologists use it. Orthopedic? Yeah, but we have agreed on several occasions that orthopedics have a very different line of treatment than what we do. Well, I mean, it is there. It's an approved drug for FDA approved drug. I don't know how many people actually use raloxifene. I don't use it.
Calcitonin nasal spray.
You use it? No. You have a question? Okay. Huh?
With vascular risk factors, including strokes, DVTs, and MIs. And as far as calcitonin, Health Canada banned it 5 years ago, even though US is still using it. And I saw that FDA approved still, but I think that's going to come in question pretty soon as well. There was a risk factor of
using raloxifene.
Sorry, the second comment I'm making is about calcitonin. So they used to prescribe miacalcin nasal spray for, especially for painful spine fractures in US a lot over the last 10 years, which has slowed down significantly. And Health Canada usually runs faster than FDA, and they banned nasal calcitonin completely about 5 years ago. The issue with raloxifene was because of its relationship with estrogenic and anti-estrogenic activity. There was remarkable, significant and concerning risk of vascular issues, including strokes and DVTs. So that reduced the incidence of usage. Some people still use it, but I just wanted to make that comment.
Professor Handa.
The problem with calcitonin came from the proof study where, the major criticism was that the dose that is approved, 200, seemed to work, and the dose of 400 international units did not work. So most people were using it only for the analgesic effect rather than for any bone protection. Injection also used to be available, but in modern day practice, I don't think anybody uses it for bone protection.
Sir, is there any role of combining teriparatide with biphosphonate in patients with very high risk factors?
Yeah, if you have a fracture, there are some proponents to use both anti-resorptive as well as PTH together. But usually they are combined after you have given an initial trial of either of these agents and not upfront. You can see the American College of Endocrinology Association with a high risk for fractures. The recommendation have not come in for combining the two upfront. Yes, Surinder.
In fact, there was a study which said that if you use them cyclically, first an anti-resorptive and then teriparatide and then that gives better results.
Yeah, that is more acceptable. That's more acceptable. Anti-resorptive than anabolic.
Sir, one question from the side. What is the drug of choice in CKD? Wherever that.
CKD, you have problem using the anti-resorptive drugs, so you give the anabolic drug.
For the maintenance then, once we have given, after that we have to maintain
you have problems of either of the anti-resorptive drugs.
You got one session on that.
Yes, Vijay Kher is doing it. So.
So what about patient on biologics and denosumab?
How are you asking questions? Are you not one of these anchor ladies? Acha, you are one of the doctors?
Yes, sir.
Oh, sorry. I am profusely apologetic. I thought he was. Yeah. Okay.
Sir, what about the patient on biologics and denosumab, sir? Can they both be used together, sir?
Yes, they can.
They can be at the same time.
Yeah.
Prevention of osteoporosis.
Nothing.
No, these are for management of osteoporosis. Anything for prevention of osteoporosis?
None of these drugs. Health, diet, and as thin as you are, that is all. Oh. I take back. You be like Rohini, you can be protected.
I think all good things comes to the end.
Okay.
So thank you very much, sir, for excellent session. Please give him a big hand. Thank you, sir. Thanks a lot.
Thank you so much, Professor R.N. Mishra, sir, for that elusive talk, sir. You had the audience certainly mesmerized by your presentation. Now, before we end this session, sir, I would like to request our chairperson to kindly felicitate our respected speaker with a memento as a token of appreciation. Sir, photo नहीं अच्छा Thank you so much, sir. Now, I would like to request Professor Dr. Rohini Handa, sir, to kindly give the mementos to our respected chairperson as well. Dr. Ved Chaturvedi, sir. Dr. Varun Dheer.
We have elephants and cows to eat from.
Dr. Danveer. Well, thank you everyone for your patient listening till now.